You're listening to the Future Tech Health Podcast with Richard Jacobs. Until I reached age 40, I never realized the obvious, that we all have medical issues, or we at least have a family member or close relation that had, has, or will have them in the future. Medicine and biological systems are the final frontier. Until we've conquered death, figured out how life began, cured cancer, and understood our purpose in the universe, there's a heck of a lot to talk about when it comes to our health. Future Tech Health means I'll be covering futuristic topics that are actually already in clinical trials, or even starting to appear on shelves or by prescription, or available for your own use. We dive deep into stem cells, CRISPR-Cas9, the science of sleep, epigenetics, medical testing, cancer, ketogenic diets, stem cells, aging, regenerative medicine, and more. My goal for you, the listener, is to learn from these podcasts. You may very well learn something that may change the course of your life for the better, steer you towards a new career, or give you insight into addressing a serious medical problem. Remember, however, this podcast and its content is informational in nature only. No medical, tax, legal, financial, or psychological advice is being given. If you enjoyed the podcast, please listen, subscribe, like, and share it with friends. Thank you. Hello, this is Richard Jacobs with the Future Tech and Future Tech Health podcast. I have Ali Tavakkoli. We're going to be talking about a pill that he's involved in developing that may help reverse type 2 diabetes, which is huge. Ali is a minimally invasive and bariatric surgeon at Brigham and Women's Hospital and Brigham and Women's Faulkner Hospital, and an associate professor of surgery at Harvard Medical School. He's the co-director for the Center for Weight Management and Metabolic Surgery, as well as the director of Minimally Invasive Surgery Fellowship. So, Ali, thank you for coming.
Thank you so much for having me. Thank you.
Yeah, tell me, what's the premise behind this pill that could positively affect patients with diabetes?
Sure. So, as you mentioned, I'm a minimally invasive and bariatric surgeon, and as part of my routine practice, we perform several weight loss operations, and one of these operations is the gastric bypass surgery. And what was a remarkable observation as we started doing more and more of these surgeries was that, as well as losing weight, many patients who were also struggling with obesity but also had type 2 diabetes, their diabetes improved very rapidly after the operation. And we have known for a very long time that if a diabetic patient who's overweight or obese loses weight, the diabetes gets better. So initially, the observation that these patients after weight loss surgery would experience diabetes improvement didn't seem very extraordinary, except that we realized this improvement in diabetes actually occurred pretty much immediately after surgery. So we would have diabetic patients who would be on metformin, would be on multiple, in fact, anti-diabetic medications, maybe even insulin. We would do the operation, and within a day or two, the diabetes would actually go away, and they would go home without any anti-diabetic medication needs. So this was a really noticeable finding. And I had been started to do some research to understand what's the mechanism underlying this anti-diabetic effect.
That's amazing.
It's really, really a remarkable observation. I come from a family where we've have many people, including both my parents, who struggle with diabetes, and I've seen the disease in various forms and severity. So this was particularly a personal issue for me, to be honest.
To compare quickly though, what happens in a gastric bypass surgery? Can you talk about physiologically what is done and what is the patient experience?
Yeah, absolutely. So, gastric bypass surgery, the way we do it nowadays, it's done as a laparoscopic or minimally invasive operation. What we do in the operation is that we start by stapling the stomach and create a small new stomach, which is roughly about the size of an egg. We then cut the intestine below the stomach and bring a loop of the intestine up and connect it to the new stomach that we have created. And as an end result of surgery, what happens is when patients eat, food travels through the esophagus, enters this new small stomach, and then from there is drained directly into the proximal intestine. And as a result of this anatomical reconfiguration, the majority of the stomach and the first part of the small bowel doesn't see food anymore. So that part of the bowel is isolated from nutrient flow.
What have people observed and gone back in, done either MRI, or, CAT scan, or gone back in for good or bad reason to see what happens to the body once the stomach has been isolated like this?
Yeah, so the stomach actually, and many of us have done this as well, is that the stomach looks actually remarkably unchanged exteriorly. So from the outside surface, when you reoperate, the stomach looks the same. So there's no kind of macroscopic change the way the stomach looks. Microscopically, so if you actually harvest the stomach or the intestine, there may be some subtle histological changes, but really nothing very small and active. It still produces acid. The first part of the intestine that's isolated from nutrient flow, it still has pancreatic and biliary secretions going into it. And those secretions, the acid, the bile, the pancreatic secretions, travels through this segment of the intestine that now doesn't see food and then meets the food that's coming through the remaining part of the intestine and the new stomach to help with digestion further down in the stomach.
How much of the intestine is sectioned off, and why section off any of it? Why not make the stomach smaller but keep as much of the intestine as possible? Does the surgery attempt to take as little of the proximal bowel of the intestine out of the loop, literally? And is it still safe to do it this way?
The surgery itself, you mean?
Yeah, like why is some of the proximal bowel, the intestine, kept out of the loop, literally?
So the reason that part of the stomach and the proximal bowel is isolated from flow as a result of gastric bypass surgery is really initially was a surgical and technical issue, because once you had created this small gastric pouch, which was thought to be the driver of the weight loss, once you created that pouch, you somehow had to drain it. And from an anatomical and technical perspective, it was much easier to bring a loop of small bowel up and attach it to it. And the fact that the remainder of the stomach and the proximal bowel was isolated from nutrient flow, I would say initially regarded as a consequence of that operation, not necessarily the primary factor that people were trying to achieve. You have to realize that gastric bypass was initially introduced in the 1960s, and at that time, obviously, our understanding of the physiology of the stomach and the bowel was much more limited as well.
It's amazing it works, though.
Yeah, it is honestly remarkable. Well, I think, the surgery was really developed, and I hate to say it, but under misconceptions that we now know are incorrect, but at the time it made a lot of sense. So what surgeons and clinicians were thinking of is that if someone is struggling with obesity, they obviously are eating too much. So they came up with they came up with two categories of surgeries. One category they call restrictive operations, and essentially the goal there was shrink the size of the stomach by stapling it and partitioning it so that people eat less, and that would lead to weight loss. And then they also came up with another group of operations called malabsorptive. And the idea there was that, well, it doesn't matter what you eat, they're going to just isolate and bypass a segment of the intestine so you don't absorb all the food that you're eating. And then there was one surgery that had a component of both. It was a restrictive operation and was thought to be a malabsorptive operation as well. And that was the gastric bypass, because it involved creating a small pouch and it also involved bypassing the first part of the intestine. So people in the era when this surgery was thought, okay, this could be a good operation because it had a restrictive and malabsorptive element. And in fact, the surgery is very effective for weight loss. It's an excellent operation for weight loss. But what we have learned over the last 4 years is that the concept of restrictive or malabsorptive are actually incorrect. And what I mean by that is that when you take a patient with gastric bypass and you actually study the food they eat, stool they pass, there is actually no malabsorption of calories or nutrients or macronutrients in these patients. And then when people also think about the concept of restriction, although people are eating less, it's not because they are physically restricted from putting more food into their stomach. It's actually just because they feel much, much less hungry. When you take a gastric bite...
what does this suggest to you? Is this the gut bacteria that has changed and that's the mechanism that causes all these changes? Or what's your thought?
The microbiome is definitely changing. So what actually is the true mechanism behind the weight loss effect and the subsequent anti-diabetic effects of the surgery that have been described has been under extensive investigations over the last 10 or 15 years. And I mentioned my lab itself has been working on this a lot. And there's no doubt that there's a lot of changes that occurs after surgery, which may contribute to the weight loss effect. So there are changes in microbiome, there are changes in bile salts, there are changes in how the intestine itself behaves. So how the surgery metabolizes nutrients is different than how it did before surgery. But the one also important finding that came out of from all the studies, all the mechanistic studies I just mentioned, is that the fact that as a result of surgery, the proximal bowel these nutrients from nutrient exposure seems to be a critical in terms of its anti-diabetic effects. And so over the last 10 years, several people started working, okay, so how can we mimic the effects of surgery without actually doing surgery? So how can we, essentially cover the proximal bowel such that it doesn't see food or there's no contact with food there, and to see if that replicates the anti-diabetic effects of the operation. And there have been devices...
So is the goal to somehow coat the stomach or parts of it, or coat the proximal bowel?
Well, probably both. So what we've done has been with LuCI is to really the main focus is to cover the proximal bowel, so the duodenum and the first part of the jejunum, and prevent nutrient exposure in that area.
Quick question going back to the bypass surgery. This is the last one I'll ask you because I know we want to focus on the pill. When the stomach is stapled and then connected to a loop of the proximal bowel, are you creating or recreating an exit sphincter for the stomach, or how would the stomach contents be kept there and resident for a period of time and then moved on to the intestine?
It doesn't. So that's an excellent question. So you're right, because in a normal stomach, at the end of the stomach, we have the pylorus, which acts essentially as a muscle and controls release of food from the stomach into the small bowel. After a gastric bypass surgery, you no longer have that sphincter. So food from the gastric pouch, from this new stomach we have created, drains into the small bowel directly. So there's no physiological control of that.
Yeah, I'm surprised that would work, and I wonder if the proximal bowel would. I mean, I highly doubt it develops its own sphincter, but I would guess that your stomach when full and your stomach when empty may act very differently without an exit sphincter, because now you're depending upon the new weight and distension of the stomach to restrict the flow of food to the intestine. Yeah. I don't know if it's restricted. Yeah. I mean, who knows?
Yeah. So I think, and I think that's a good point. I think the fact that you don't have that sphincter leads to a separate set of issues that we see in patients with gastric bypass, and that's really a side effect of operation, and that is because the food can go directly from the gastric pouch into the small intestine very quickly, and there's no kind of a control mechanism there. Sometimes patients develop what we call dumping syndrome, which is a side effect of surgery. But that's the mechanism behind that is really as a consequence of surgery, and it's a side effect of operation rather than a desired effect.
Yes, this makes sense what you're working on, because it would be much better to keep all the the physiology there, but just selectively, I guess, coat sections so that they act differently and process differently, right?
Yeah, exactly. And I think, this is, when you step back and look at the gastric bypass surgery and its anti-diabetic effects. So, I mentioned the anti-diabetic effects are really strong. Many patients within a few days of operation are home without any diabetic medications, and the hemoglobin A1C and all parameters starts to normalize. There have been over 11 randomized studies that have compared gastric bypass and bariatric operations to the best medical treatment for management of diabetes. And all of them have shown that gastric bypass and bariatric surgery are superior to best medical treatment in terms of managing diabetes. So there is really an overwhelming amount of evidence that in an obese type 2 diabetic, this could be the best treatment. And many, U.S. and international diabetic societies have now incorporated weight loss medications in the treatment algorithms for type 2 diabetes. So it's actually there and stated. The issue, though, is that about only 1 to 2% of patients who qualify for surgery actually ultimately end up having the operation, which is a real paradox. You have, because it's a really paradox. You have this chronic disabling disease. You have a procedure that's known to be very effective for its management, yet not many people have it. And to be honest, the reason people don't have it is probably multifactorial. So, part of it is access to care, part of it is health insurance, but a bit is that also, maybe other providers, the PCPs and endocrinologists are reluctant to refer patients for a major operation because of, surgical risks. And also other part is because just patients don't want to have a surgery which has some side effects that I just talked about, and leads to essentially permanent change in GI anatomy. And that because of that, I think we've been really excited about this concept of LuCI, because I think by replicating the physiological changes that have to occur after gastric bypass, and hopefully replicating its powerful anti-diabetic effects without actually doing an invasive operation, a lot more of the type 2 diabetic patients would be able to benefit from the anti-diabetic effects of a gastric bypass surgery. So essentially have a surgery in a pill.
So, all right. So what's how does the pill work? What does it do? And what's the method of action?
Sure. So the kind of concept here is that we provide a transient coating of the proximal bowel such that when patients are eating the food, although it goes through the bowel, the mucosa and the lining of the bowel doesn't see the food. So for all intents and purposes, it feels isolated from nutrient exposure. And so the concept essentially replicates what we see with the gastric bypass. We wanted this coating to be transient. And the reason for that is that gastric bypass patients, we often see high vitamin deficiencies, because the part of the intestine that is isolated from nutrient flow is actually very important for absorbing some vitamins, such as some vitamins and minerals and other micronutrients. So specifically iron, B12 and vitamin D and calcium. So we wanted our barrier transient so that patients can take their multivitamin or other supplements at a separate time and minimize the risk of developing any micronutrient deficiencies. So when we started to explore potential material to help us create this, we developed an in vitro model, and the details of this are all in a paper that we had published in Nature Material about a year ago. But when we tested many materials in this in vitro chamber we had created, we came across sucralfate as a potential material that is very good barrier to glucose and glucose absorption, but it's also very durable. And sucralfate was a particularly interesting option because it's a drug that has been available and FDA approved for over 30 years, and patients use it for treatment of gastric and duodenal ulcers. And what sucralfate does is actually, when you ingest it, it gets activated by the acid in the stomach, forms essentially kind of a paste-like material that sticks to ulcerated mucosa and allows it to heal. And so we said, well, maybe we can give sucralfate to a diabetic animal and see if sucralfate actually makes their diabetes better. And when we tried that, it actually was not effective. And the reason it wasn't effective was that the sucralfate wasn't able to adhere very well to healthy intestinal mucosa. So that started a 7-8 year collaboration with Jeff Karp, my collaborator, who's been involved with this project from the beginning, to see how we could modify sucralfate and create a version of it that essentially is capable of adhering to healthy mucosa. And the other quality we were interested in, we wanted the new material to be pH independent. So what I mean, not depend on the gastric pH to be activated. And this ultimately led to creation of a new formulation we called LuCI, which stands for luminal coating of intestine. And what we've shown is that LuCI is capable of actually forming after you take it in a pH independent fashion. It's able to get hydrated in the stomach. It forms a paste, which instantly forms a uniform coating on the proximal bowel. And you do know that it's the proximal bowel and not the stomach, or could it be both the stomach and the proximal bowel? That's a good question. It's actually, we've done some CT imaging in rodents who've had LuCI, and we get a little bit of coating in the distal stomach and also some coating in the proximal small bowel. So you're right, we get a little bit of both, and that's, I think, good. We believe that most of the antidiabetic effects probably drive from that isolation.
Any chance that it might build up around the exit, the pylori, the pylorus in the stomach, and prevent it from closing properly, or get dumped up in the sphincter?
Yeah, so good thought. Yeah, no, I mean, the paste is not that thick I believe, to cause an obstruction, to be honest. And also, we have done now chronic experiments in rodents where they had LuCI once or twice a day for about 5 or 6 weeks, and there was no suggestion of that.
So have you seen experimentally that it's blocking certain? I mean, it can't block everything, but I guess it's blocking certain nutrients, right? Is there a profile of what it blocks and why?
Yeah, so I think, what I would say is that in the proximal bowel where this coating is created, it probably reduces or blocks nutrient absorption in that segment of the intestine very well. However, similar to the gastric bypass, by just isolating absorption in that area, it doesn't mean that we're going to cause nutrient malabsorption. So what I mean by that is that, let's say, proteins or sugars or whatever that are going through the intestine, if they don't get absorbed in part isolated, they will probably get absorbed in the more distal segments of the bowel. And what happened as a result of this is that because the topography and the timing of nutrient absorbers has changed, that leads to neurohormonal changes, which are good for treatment of diabetes. So as an example for that, for example, is that, let's say, glucose is, if the proximal bowel is coated and it's not, the glucose is not absorbed, that glucose absorption occurs in the more distal bowel, and that because of its pattern and change in absorption pattern leads to changes in secretion of some hormones. An example of that is a hormone called GLP-1, which is a very potent anti-diabetic hormone. And we've seen that in our rodent models, is that after administering LuCI, you do see changes in these beneficial anti-diabetic hormones as well.
If you consider the lack of absorption as a, I guess, reduction in residence time or transit time through the body, in effect, how much less time is a given bolus of food going through the body? The body's, I guess, not, I'm assuming the body's not, quote unquote, seeing it for a period of time, and it's seeing it only later on in the process. So it's essentially seeing it for less time. I don't know if that's a good way to look at it.
Yeah, no, yes. So maybe two ways to answer that. So I think we haven't necessarily, and obviously we'll need to continue to study this, but we haven't seen obvious changes in intestinal transit. So what I mean is that it doesn't appear like the bowel is pushing the material through faster. So I don't believe intestinal transit is changed. However, because let's say the proximal bowel is not seeing the food, and the food is delivered more distally, I guess you're right. There may be the argument that there's less surface area or less. I think time may be less of a factor because it goes through pretty quickly anyway, but there may be less surface area of the bowel to absorb the food. And I would say that in the case of the small intestine, there's such a redundancy of the mucosal surface area for nutrient absorption that I think that per se is probably not an issue. I don't know if I answered your question appropriately.
Yeah, no, I got you. So is the coating preferentially blocking of glucose, or can it be tailored and tweaked to block or coat against certain macronutrients versus others?
Yeah, so wonderful question, and I think that's what we're going to continue to do. Certainly, LuCI, there are ways for us to adjust viscosity and the thickness of LuCI and affect its duration and the barrier qualities. I think the work we have done so far has really been mostly focused on glucose changes, but that could be a future direction looking at other macronutrients as well. Our focus has really been mostly on glucose and its effect on diabetes.
Yeah, so, okay. So in rodents, this has had a pretty dramatic effect on rodents with diabetes or their glucose absorption. Like, what are some of the parameters you've evaluated, and what has changed with use of the pill?
Yeah, so as I mentioned, we have looked at changes in oral glucose tolerance tests after administration of LuCI setting. And we've seen a significant reduction about a 47.3% reduction in incremental area under the curve in oral glucose tolerance tests before versus after LuCI administration, which is very impressive. And we have also started to do some chronic experiments where we have given LuCI to animals like for 5-6 weeks. And part of that was we wanted to make sure there's no evidence of toxicity on LuCI. So we wanted to make sure the animal doesn't develop any overt diarrhea, or we've actually taken the intestine and analyzed the intestine, and there's no evidence of damage to the intestinal lining or anything after the surgery. So that's great. And in these chronic experiments, we have also started to see some weight difference between the animals. So the LuCI treated animals have lost around 7 to 10% weight with LuCI as well. And we're also showing that after LuCI administration for several weeks, in a model, in a kind of an insulin-resistant animal model, we're seeing a reduction in degree of insulin resistance, a decrease in fasting glucose, and also we are seeing some changes in some of the beneficial hormones that are relate to diabetes. So we see an increase in GLP-1 levels, as I mentioned before.
So how long does it take after you ingest the pill for it to work, and how long does it appear to last?
So, the experiments we've done, usually we give the LuCI before oral glucose tolerance test. And usually we give it about an hour or so before. I suspect LuCI can be effective even if given closer to the oral glucose tolerance test or food ingestion. And then the effect lasts for about 3 hours, and after that starts to kind of wean off and tailor off. And by usually 24 hours, we see no residual effects. Most of it is gone at that point.
Okay, so this would be, I guess, taken before meals. Is that the
again, exactly. That you take it before meals, and potentially maybe even just twice a day. And that provides the barrier during the time of the day when most people have to take food.
And then, has anyone looked at the feces of people before and after they've had bariatric surgery? And also, in your animal models, have you looked at the feces of the rodents before and after they've taken these pills to see how it affects them?
So that's excellent. And in terms of the animal models and LuCI, that's actually an area of studies we're currently doing, and we're very much interested in that. So we're looking to look at the amount of stool output and also consistency, and also to see if there are changes in nutrient contents in the stool. And, a lot of people nowadays are interested in microbiome changes after various drug administration. We're interested in the effects of LuCI on that, and that'd be a future direction as well. In terms of human studies in gastric bypass, so there is, people have done that. So in human models of gastric bypass, as I mentioned before, there's no evidence. So there's no evidence that a standard gastric bypass causes any diarrhea or evidence of macronutrient absorption. There is definitely microbiome changes, and whether that's the primary driver of the effect of surgery is still in a big question. It probably isn't the primary driver, to be honest, but just a side effect of surgery. But those are areas that are under evaluation.
Yeah, one company I spoke to a long time ago, they thought that entrained air now made it into the intestine, the small intestine, because of the lack of sphincter and, the smaller stomach size and everything. Has it ever been a factor on your guys' radar that could change the microbiome from anaerobic to more aerobic?
I've heard some of that work before as well. So I think, it's an interesting theory, and I don't know all the data for it, to be honest with you, but it's an interesting thing. I would say, in terms of what we're focused on, which is the anti-diabetic effects of surgery, is that the important point is that we see this anti-diabetic effects very quickly after surgery, like literally within a few hours. So I suspect there is maybe multiple complicated mechanisms involved with this, and it may not be just a change in microbiome, although that may occur that are driving this, because it would be too quick to see these microbiome changes within a few hours after surgery, to be honest.
Yeah, you're right. Well, it's a complicated but fascinating thing you're working on. What's the schedule ahead for the clinical trials? Like, what's the path ahead? How long?
Yeah, so as we incorporated and formed a startup around this idea of LuCI. The startup is called Ultrix Bio. Our CEO is Nancy Briefs, and we've been around for about 8-9 months now, and we have started essentially working with a manufacturing process to make sure we can create the capsules for our first in-man studies. We have had some initial informal discussions with FDA, and our goal is that once we have the manufacturing process confirmed, to have our first official meeting with the FDA to review our trial designs, hopefully get their approval, and then hopefully by towards the middle to end of next year, do our first in-man studies. So we're very excited about it and looking forward to that.
So how long would you guess that it may take for this to become commercially available or available, through your doctor?
Yeah, so, I think drug development pathways are usually long and complicated, but I think we have a few things going for us, which I think would suggest this is going to be, we may have a shortened time. So one of them is that because LuCI is based on already approved drug, namely sucralfate, which has been around for a while, and because LuCI doesn't have any systemic absorption, it really just works on the gut by creating the coating. There's no systemic absorption of the material. We're hoping to go down a 505(b)(2) approval pathway with FDA. We've had several discussions with consultants who feel that should be a doable path. And I think if that all goes well, there's time to be completing our phase 1 and maybe go to a phase 2 and have some positive data for the next steps would be potentially 3 to 5 years.
Okay, that's not terrible. Yeah. Well, excellent. Any last points that I know there's endless things to ask, but anything else you want to put forward about it that's important for people to know?
No, I think really just the idea that I think the key message for me and what has really made me excited and committed to this field has been that the surgery really just has very dramatic beneficial effects on diabetes. And if we can replicate that in a less invasive fashion, I think there is a tremendous value that we can offer to patients who struggle with really otherwise a chronic disabling disease, which currently is the whole treatment algorithm is based on escalating treatment. Like you add one drug, it works for a little bit, then the diabetes gets worse, you add a second drug. Diabetes gets worse, you add a third drug, it gets worse, you add insulin. And here you actually have the potential opportunity by giving a drug which puts the disease in remission. If we can replicate the effects of gastric bypass, the disease actually goes in remission. So actually people can reduce the number of medications they take. Many people can come off the medications completely. So it's a very exciting potential approach. And as someone who's lived with family members with a disease, it's particularly important.
Yeah, and without surgery. So that's another great thing.
Yeah.
Well, excellent. So, Ali, how do people find out more about LuCI and get in contact if they want to know more?
Sure. So we have our website is altrexbio, altrexbio.com, altrexbio.com. And we have a website out there. We're actually currently working on it and increasing information. We will put our presentations there, and we've been asked to give some talks nationally, internationally on the topic. So we will try to summarize all of it and also the progress that the company is making.
Excellent. Well, Ali, thank you for coming on the podcast. It's been great.
Thank you.
You're listening to the Future Tech Health Podcast with Richard Jacobs. Until I reached age 40, I never realized the obvious, that we all have medical issues, or we at least have a family member or close relation that has, or will have them in the future. Medicine and biological systems are the final frontier. Until we've conquered death, figured out how life began, cured cancer, and understood our purpose in the universe, there's a heck of a lot to talk about when it comes to our health. Future Tech Health means I'll be covering futuristic topics that are actually already in clinical trials, or even starting to appear on shelves or by prescription, or available for your own use. We dive deep into stem cells, CRISPR-Cas9, the science of sleep, epigenetics, medical testing, cancer, ketogenic diets, stem cells, aging, regenerative medicine, and more. My goal for you, the listener, is to learn from these podcasts. You may very well learn something that may change the course of your life for the better, steer you towards a new career, or give you insight into addressing a serious medical problem. Remember, however, this podcast and its content is informational in nature only. No medical, tax, legal, financial, or psychological advice is being given. If you enjoyed the podcast, please listen, subscribe, like, and share it with friends. Thank you.